Welcome back, everyone. And let me introduce our next guest, who's Dr. Sergej Ostojic from University of Novi Sad, Serbia. Welcome.
Hi, guys. It's a great pleasure to be with you today and perhaps share some interesting insights about creatine and post-viral fatigue syndrome in the light of COVID that we are facing all across the world. Before I begin this lecture, I would like to thank Dr. Krader and Dr. Stout, who invited me to give this presentation and prepare a paper for the special issue of nutrients dedicated to creatine. Probably the best piece of work with comprehensive evidence about using creatine across the health domain, from the field of sports science to the medicine. It's a really great pleasure to be a member of this team. And during the next 40 minutes or so, I'm going to talk about the creatine for this really mysterious and sometimes very perplexing conditions such as a post-viral fatigue syndrome. So first of all, I'm going to give you a short background about the syndrome, highlight some of the fundamentals of post-viral fatigue syndrome, and also perhaps provide in more details links between the post-viral fatigue syndrome and creatine metabolism across the different matrices, including the blood or urine, even the level of creatine metabolism in the brain and the muscle of patients suffering from this condition. After that, I'm going to give you some overview of studies that evaluated creatine intake in post-viral fatigue syndrome, and perhaps discuss a little bit more about the possible mechanisms of creatine action in post-viral fatigue syndrome, although no studies so far really evaluated the exact mechanisms of creatine in the post-viral fatigue syndrome, also known as chronic fatigue syndrome. Many open questions remains in this field of creatine application. Some of them are going to be addressed in more details by the end of the lecture, as well as the possibility to use creatine in post-COVID-19 fatigue syndrome, probably the highly prevalent condition that is going to track us down in the next years and years, having in mind so many people that have actually experienced this kind of problems at this moment across the world, and give at the end of the presentation give few take-home messages or conclusions. So post-viral fatigue syndrome at the beginning actually was reported for the first time in scientific literature in 1950. The group of authors from Iceland, Sigurdsson and co-workers, actually described a very mysterious disease epidemic that they saw in Iceland that was really similar to poliomyelitis that was very prevalent back in the day. During the winter of 1948 and 1949, Sigurdsson and his colleagues really tracked down over 400 cases in a small city of Akureyri in northern Iceland. They described and eventually monitored those patients who really have several different attributes of unknown disease. Actually, that was somehow summarized in this slide, and including the induced onset of symptoms, also low-grade fever with headaches in some patients. They also reported pain across the body, but mainly in the back and in the shoulders. Muscles were very tender to touch and painful, but the general and probably the most important problems in terms of subjectively reported attributes was fatigue. And that fatigue actually appeared even after the slight exertions. Many patients have reported problems with sleep, also excessive nervousness. Several of them reported emotional disturbances, and that symptoms and signs lasted for weeks and weeks, even in many months. So no exact reason or etiology has been revealed back in the days, but the Sigurdsson and his colleagues continued to follow the patients, this group of patients, for the years to come. Published a kind of follow-up after 6 years of that Accuray disease, and the paper has been published in Lancet. This is the actually the editorial of that specific for that specific paper. Sigurdsson et al. Actually reported that many of the patients, even after 6 years after the onset of the disease, still complained of many features of that Accuray or Iceland disease, including the nervousness, tender muscles, pain across the body, and the general fatigue. So the editor of Lancet decided to really describe this perplexing condition in the editorial, suggesting that we are talking here about a new clinical entity. And he suggested back in the days the term benign myalgic encephalomyelitis might be acceptable, and that term is also used in the following decades pretty often. But the authors of the editorial also suggested that we have to really better address many different aspects of this perplexing syndrome in more details. Finally, when we come to 2022, we could easily see that right now the syndrome has been identified by the WHO through the ECD-11, or International Classification of Diseases, the recent version of it, as a post-viral fatigue syndrome with the code 8E49. And this syndrome should be really used as, and the name of this syndrome should be really used as most important as comparing to previously used synonyms, including the chronic fatigue syndrome or myalgic encephalomyelitis. And definitely post-viral fatigue syndrome should be observed apart from the different fatigues seen in medicine that are not related to the post-viral infection like this syndrome. Very nice paper published in 2020 actually described the post-viral fatigue syndrome in terms of pathogenesis, prevalence, and also included a couple of information about the possible aspects of post-viral fatigue syndrome in general medicine. The authors evaluated several public databases from 1980 to 2018, and they actually included 46 studies with over 1 million participants, and the prevalence data was from 0.01 to 7.62, so it's really a high range of prevalences, probably as a consequence of hard to diagnose conditions such as post-viral fatigue syndrome, and the mean prevalence is a little bit lower than 1%. Also, the PVFS or chronic fatigue syndrome has been more often seen in women as compared to the men, and also in adults it's a little bit more often as comparing to children and adolescents. But you could see easily that the problems in diagnosing this complex syndrome might be related to the way how you diagnose it, because it's more often diagnosed via interviews, who appears to be more clinically rigorous as comparing to the general physician diagnosis that include various syndromes, and they provided a really nice map suggesting that probably the fatigue cognitive impairment, and also sleep disturbances are in the center of diagnosis paradigm, while this syndrome also might be accompanied by orthostatic intolerance or myalgia, also muscle weakness. That is really not fundamental elements in diagnosing this mysterious syndrome. There are a couple of professional bodies across the world that develop the diagnostic criteria for post-viral fatigue syndrome, including the CDS. And this is probably the nice summary of diagnostic criteria, including the several bodies also in Canada, international consensus criteria, and CDC, suggesting that post-viral fatigue syndrome appears when the fatigue appears and stay persistent for more than 6 months, and that fatigue appears to be very severe. Another interesting aspect of post-viral fatigue syndrome is actually a post-exertional malaise lasting more than 24 hours. So the patients are usually not responding well to the exercise. They feeling really fatigued after the end of the even slightest exercise. But also the problems with cognition, including the short-term memory or concentration, appears to be highlighted. And so far, the post-viral fatigue syndrome is considered as a part of neurological diagnosis. So it's a neurological disease. Post-viral fatigue syndrome is also often followed by sore throat, tender lymph nodes and muscles, and the pain that we are seeing often in post-viral fatigue syndrome is seen across the body. It's multi-joint, but no swelling or redness, like for instance in arthritis. Headaches are pretty often with varying types and patterns and severity, and the sleep problems are often here. But if you follow the guidelines, you will see that most of the review papers or guidelines really are not able to address what is the cause of the post-viral fatigue syndrome. So we still don't know what is the cause of the post-viral fatigue syndrome. There is no clear pathognomonic diagnostic criteria. So there is no single test that we could really use to diagnose 100% as a gold standard that the person has a post-viral fatigue syndrome, as well as no approved medical treatment. So it's really perplexing. We don't know what caused it, we don't know how to diagnose it, and we don't know how to treat it, but it appears to be more prevalent really using these surrogate markers. It's interesting that post-viral fatigue syndrome is, like the name says, is often preceded by a viral infection, but not always. Several viruses has been already demonstrated to induce post-viral fatigue syndrome, including the Epstein-Barr virus or cytomegalovirus, Coxsackie viruses, as well as coronaviruses, even between the COVID-19 disease, but also a very nice overview of possible etiological factors identify many non-viral contributors, including the family history that might be an important aspect, as well as autoimmune diseases and other immune system abnormalities that often accompany post-viral fatigue syndrome, or people who already have a kind of sleep disturbances or sleep disruption, more often suffering from post-viral fatigue syndrome, psychiatric disorders, and probably creatine shortfall might accompany the post-viral fatigue syndrome, and I'm going to address that in the next several slides. So probably the first trial that really described the possible changes in some biomarkers of creatine metabolism or utilization or enzymes that are related with creatine has been published in 1988. Actually, the 96 patients with post-viral fatigue syndrome had mildly elevated CK levels in the blood. And besides that, the enterovirus RNA was present in the skeletal muscle of some patients up to 20 years after the onset of disease. So it appears that the virus stays in the body and might induce a kind of stress of the muscle fibers that might eventually induce that mild elevation of CK levels, which is often above 300 units or even 400 units. Another couple of studies followed this pioneering research on creatine metabolism and post-viral fatigue syndrome, and they're both published in 1993, evaluating approximately 2 or 3 dozens of patients. And the first one, published in Journal of Clinical Pathology, found some minor abnormalities of skeletal muscle fibers in patients with post-viral fatigue syndrome, but they didn't find any really important or significant differences in CK levels of the level of plasma carnosinase. Mean muscle RNA composition was reduced by approximately 15% in acute onset post-viral fatigue syndrome. Another trial recruited 35 patients with post-viral fatigue syndrome, and authors found basically no big differences in terms of electromyographic or muscle histopathology studies in the patients suffering from post-viral fatigue syndrome, but they did found abnormal fiber density in some patients who did not have acute onset of the syndrome. The plasma CK levels appears normal in this population. Another study published 1 year later evaluated indicators of creatine metabolism in post-viral fatigue syndrome in 10 patients, and they did found the kind of mild abnormalities examining the muscle by histological assays. They found the microphage infiltration as well as the muscle fiber atrophy in those patients, but other conventional safety biomarkers, including the liver, kidney, and muscle enzymes, as well as the level of protein, were really insensitive to discriminate the patients and other myopathies. So there is no something from this study that appears to relate creatine metabolism, impaired creatine metabolism with post-viral fatigue syndrome. In the study that evaluated 16 female patients suffering from post-viral fatigue syndrome, and females are generally more often have actually has this kind of problem, there is no differences in the biomarkers, but it appears that immunity might be compromised in relation with CK metabolism. The authors found actually that stress-induced neutrophil mobilization was disrupted in the population of patients. Healthy women demonstrated a strong correlation between exercise-induced neutrophilia and plasma CK, while this link was not observed in the chronic fatigue syndrome patients, like shown in this slide. Magnetic resonance spectroscopy studies started to evaluate this population back in early 1990s, and the first study, at least known to me, has evaluated 22 patients suffering from chronic fatigue syndrome, and they were evaluated through a series of different tests, and the authors found actually that patients have a shorter duration of exercise, and also they reach exhaustion much more rapidly than normal subjects. It's interesting that energy metabolism might be compromised in this population, at least due to the lower ATP levels at the exhaustion in the group of patients, but there is no difference in muscle phosphocreatine levels between the patients and the normal subject, both at the rest and during the peak exercise. Additional series of spectroscopy studies evaluated comparatively small number of patients, up to 46, and some of them didn't found any major metabolic abnormalities in muscle bioenergetics. But study published in 1993 found the impaired the relationship between the level of phosphocreatine and pH pH during the exercise. The second one also found the reduced maximal rate of post-exercise PCR resynthesis in the group of chronic fatigue syndrome patients, suggesting that the perturbation in energy metabolism might be driven by those problems with creatine. Finally, the study from 1998 in 35 patients found decreased resting values of creatine to phosphocreatine, suggesting a possible shortfall of creatine, or at least disturbances in creatine resynthesis in chronic fatigue syndrome patients, while the level of pH increased during exercise. Not just the muscles are suffering from the chronic fatigue syndrome. An interesting spectroscopy study evaluated the level of energy metabolism and different biomarkers in the brain of patients suffering from chronic fatigue syndrome. Although the study was comparatively small with only 7 patients, actually the authors reported the change in the levels of N-acetyl aspartate in the right hippocampus. The levels were reduced in these patients as comparing to normal subjects, suggesting some kind of reduction of general metabolism and cell viability. But also it is interesting that a non-significant trend was found for reduced levels of hippocampal creatine, with the levels approximately 8.6 as comparing to 10.9 so 9 in healthy control. So 15 to 20% of decrease in level of creatine has been suggested here, and authors actually really consider the possibility that chronic fatigue syndrome might be accompanied by impaired brain creatine metabolism. The same situation happens with children. This is the study highlighting the effects of chronic fatigue syndrome in pediatric patients. Only 3 pediatric patients has been evaluated, but it appears that many different both vascular and metabolic alterations has been found in the children who suffered from this complex disease, including the lower blood flow in some part of the brain, including temporal and occipital lobes, and the higher blood flow in other parts of the brain, including basal ganglia and thalamus. They also found the elevation in choline to creatine ratio, which is regularly and probably the most popular index of brain metabolism used through magnetic spectroscopy. It's really a shame that they didn't really report the individual levels for brain metabolite, but just ratios. So this might suggest even a reduction in brain creatine or an elevation in brain choline in the pediatric patients suffering from this complex disease. In 2001, there is a very good paper published in Lancet suggesting that patients who did have post-viral fatigue syndrome after the hepatitis C, they have definitely different ratios of choline to creatine comparing to normal population. It appears that the levels were also increased for both basal ganglia and white matter regions of the brain in 30 patients suffering from post-viral fatigue syndrome. This is another study suggesting that either creatine is lower or the choline is higher in the patients with this disease. A higher choline to creatine ratio was also found in the occipital cortex in another study with 8 patients, and also in the basal ganglia reported here, with the difference definitely found for several indicators of brain metabolism. So creatine might be one of the affected metabolites in the chronic fatigue syndrome or post-viral fatigue syndrome. Finally, the heart might be also suffering from kind of impaired energy metabolism in post-viral fatigue syndrome. In 12 patients suffering from this disease, it appears that mean phosphocreatine to ATP ratio was lower, with every third patient had PCR to ATP values consistent with cardiac impairment. This was accompanied by reduced maximal initial proton efflux rates, and those patients have prolonged half time for PCR recovery from the AD exercise. So either the creatine was lower, or those patients need extra time to recover to set up the creatine levels in the heart close to the normal levels as compared to the control group. A nice study has been published a few years ago in Biological Psychiatry, evaluating 89 women with post-viral fatigue syndrome. It's interesting that more pain in those patients was associated with reduced gray matter volume and decreased NAA to creatine ratio in the dorsolateral prefrontal cortex. So brain metabolism is definitely affected in a woman with chronic fatigue syndrome, and probably creatine might be involved in this impaired metabolism for at least for a woman. Brain creatine levels and post-viral fatigue syndrome are also evaluated recently in another study, who suggested that elevated choline to creatine ratio has been found in left anterior cingulate region, and those ratios suggesting perhaps lower level of brain creatine correlated well with fatigue in many brain regions. Particularly, we found here that in some parts of the brain, the creatine was lower in patients with post-viral fatigue syndrome, such as the parietal cortex, where the creatine was approximately 10% lower as comparing to healthy controls. But in another part of the brain, putamen, for instance, creatine was higher in post-viral fatigue syndrome. So we already know that there is a different distribution of creatine, the density of creatine transporters across the brain. So probably different parts of the brain respond differently in terms of creatine metabolism in patients suffering from post-viral fatigue syndrome, suggesting that it might be a location-specific variation in brain creatine. Another finding for this study actually suggested that the temperatures across the brain were higher in patients as compared to the healthy controls, probably due to neuroinflammation or mitochondrial dysfunction, or even impaired communication between the neurons that might really be a problem with patients of chronic fatigue syndromes. Some urinary biomarkers of creatine metabolism might be seen in patients with post-viral fatigue syndrome. This is actually not a study describing the chronic fatigue syndrome, but a similar condition, fibromyalgia, and 80 patients suffering with this syndrome demonstrated an elevated level of creatine excretion via urine, and that creatine urinary loss correlated pretty well with severity of the fatigue and pain. So the authors actually tried to address this a little bit more details, and they developed an algorithm for the diagnosis of fibromyalgia syndrome, consisting of 3 fundamental metabolites that have to be evaluated in the urine. And besides the succinic acid and taurine, the creatine might be the biomarker that has a good level of accuracy in terms of diagnosis, particularly for the pain and fatigue symptoms in this condition that is very similar to post-viral fatigue syndrome. The advances in metabolomics actually has been harnessed to diagnose better the post-viral fatigue syndrome. This is the paper evaluating the 46 patients, and the metabolomics analysis found among many different biomarkers the level of urinary creatine that has been elevated in patients from chronic fatigue syndrome, as well as the decreased serum glycine. Since the glycine is one of the precursors of creatine, this study actually might suggest that somehow the utilization of creatine might be elevated in chronic fatigue syndrome. One of the biggest biobanks available at this moment, UK Biobank, also has been thoroughly evaluated for chronic fatigue syndrome patients, and this is one of the biggest studies so far, with 272 patients suffering from post-viral fatigue syndrome evaluated for their metabolism. And it appears that patients with severe disease have a lower CK levels compared to the healthy controls and non-severe patients, even when we adjust this correlation for various demographic indicators, including the sex or age or body physique, even the muscle mass and disease duration. So it might be possible that actually the creatine metabolism has kind of different dynamics related to the severity of disease, changing from a lower to higher utilization. And we, of course, have to do much more studies to understand what happens with the creatine metabolism throughout the course of the disease. Another recent study from the same database evaluated the 15 patients suffering from chronic fatigue syndrome, and the authors found that the levels of CK in the blood were lower in patients with severe post-viral fatigue syndrome than in the healthy controls. And those changes were actually accompanied by differences in other biomarkers, including the microRNA profiles or other indicators of immunity, such as number of peripheral blood mononuclear cells and also extracellular vesicles. They suggested that actually the chronic fatigue syndrome might be related with various impairment of various pathways that include both neuronal and endocrine metabolic system, including the upregulation of genes related to the development and survival of neurons, and also downregulation of chromatin and RNA mediating silencing genes such as AGO2 or MCP2. Definitely, we have to address the issue regarding the changes in creatine metabolism in chronic fatigue syndrome in much more detail. So many open questions are there, but still, I think that for sure we have to really account for many issues that are not included often in the studies, such as for instance, the duration of the disease or gender. But still, no matter how many issues remain to be addressed, couple of studies already started to track down the creatine as a possible treatment, therapeutics, or kind of additional nutraceutical that might help people suffering from post-viral fatigue syndrome. Through the literature, we didn't found really any interventional studies published so far that evaluate the level of the effects of supplemental creatine in post-viral fatigue syndrome. So far, a couple of studies evaluated either the multi-component supplement in this population or evaluated the effects of creatine in similar conditions such as fibromyalgia, or using creatine precursors such as GAA or guanidinoacetic acid in chronic fatigue syndrome, or some of the data actually were used from cross-sectional studies comparing, for instance, the level of intake of creatine-rich foods in the population who are suffering from creatine for chronic fatigue syndrome. So I'm going to address this in more details. The first study known to my group about the creatine and chronic fatigue syndrome has been published 20 years ago. And I think it's a group from the Netherlands, from Radboud University Hospital, that recruited 27 patients and 26 control in randomized control trial, and they actually administer the patients with multi-component supplement that contained approximately 1.2 grams of creatine per 100 milliliters, with many, I think over 40 different additional compounds or micronutrients. The initial interaction period was approximately 10 weeks, and the study evaluated various outcomes, including the fatigue, magnitude, clinical symptoms, and physical activity. And the study really didn't find any significant differences between this multi-component supplement and placebo. You could see the summary of the results table on the right side of the slide, with no big differences between two interventions, placebo or the supplement. But still, this study is relatively limited due to really no assessment of nutritional status prior to the treatment, or really it's not easy to tell what appears to be fundamental element of the component. So many elements are involved, so some might be even having a contrasting characteristics working against each other. And the creatine dosage was definitely pretty low, having in mind the fact that most of the studies use the regimes of administering creatine 3 grams per day or more. Bruno Galano and his group did a very nice study evaluating the effects of creatine in fibromyalgia patients. They administered creatine during the 16 weeks in a traditional regime used often in sports, with 20 grams of creatine for the first 5 days, followed by 5 grams per creatine throughout the end of the trial. And they did a nice evaluation of many outcomes, including the cognitive performance, sleep, but also tissue metabolism and muscular performance. You could see here that an intervention with creatine actually induced a higher levels of phosphocreatine in the muscle on the panel A, and also the creatine intervention improved the mental health domain of health-related quality of life, evaluated with SF 36 SF questionnaire, as well as the positive effects of creatine on the dynamic and isometric muscular strength. Regarding the cognition, Golano and coworkers found improved memory, incidental memory, from the delay recall test and the end of the trial. Another study related with creatine and or creatine related compounds in chronic fatigue syndrome has been conducted by my group a few years ago. We actually also conducted a randomized controlled trial with 21 mid-aged women suffering from chronic fatigue syndrome. We used back then the precursor of creatine, guanidinoacetic acid, and we administered it for 12 weeks, 2.4 grams per day. We did found the elevation in the level of creatine in the muscle, and also improved performance in terms of quadriceps isometric strength, as well as the VO2 max. And also we did found some promising results in terms of fatigue related to the subdomains of fatigue, as evaluated with MFI 20 questionnaire regarding the activity, motivation, and mental fatigue. But we didn't find effects on general fatigue and muscular soreness at rest and during activity. This suggests that creatine analogs such as GAA might have beneficial effects in this population. Regarding cross-sectional studies, I found two interesting studies published also some time ago. The first one suggested that there is a really specific dietary habits and food avoidance behaviors in patients suffering from chronic fatigue syndrome. They often avoid many foods rich in creatine, such as red meat. So it might be related to the poorer creatine turnover in those patients, as well as the second study suggesting that people suffering from chronic fatigue syndrome have lower intakes, actually below reference ranges for animal-based nutrients. So it might be that low creatine consumption from food actually be involved in impaired creatine metabolism seen in chronic fatigue syndrome. That might call for compensation through the prescription of creatine-rich foods and creatine supplementation. Although no study so far really evaluated the mechanisms how creatine might work in post-viral fatigue syndrome, this is just a figure suggesting that it might work through different mechanisms, including the inflammation suppressor or antioxidant activity. We already probably know that creatine is effective as a good facilitator of ATP recycling, but perhaps acting as a glutamatergic modulator through different channels and transporters and glutamatergic modulators might be another way how creatine might affect post-viral fatigue syndrome. And also, we know that creatine might affect mitochondrial pores, and it is another way how it acts as a neuroprotection. Still, many open question remains regarding the use of creatine in post-viral fatigue syndrome. We have to describe that possible deficiency of creatine in terms of demographics, including the age, gender, ethnicities, also comorbidities, as well as the disease duration and severity, and perhaps some tissue-specific models for creatine uptake in the disease. Definitely we need to understand better what is the perfect intervention protocol in terms of, acute phase or recurrent episode of post-viral fatigue syndrome, since we are dealing with long-term disease. Perhaps we have to address possible mechanisms of creatine action besides the energy-related buffering to found the optimal dosage and formulation. But probably the situation we're facing right now with post-viral fatigue syndrome following COVID might be something that is a really good opportunity to address both the effectiveness and safety of COVID in this population. We are conducting a study right now, and soon I hope we will have results to share with the community regarding the effects of creatine administered in this specific post-COVID patients. I addressed this issue recently in therapeutic advances in respiratory diseases because the International Task Force of the European Respiratory Society really suggested that nutrition might be an important element of rehabilitation after COVID-19. So in the survivors of COVID-19, we might expect the post-viral fatigue syndrome and creatine might be effective, having in mind its effectiveness across the really different pulmonary conditions, including COPD or cystic fibrosis, or even the respiratory failure. We already know it's very safe, it's inexpensive and widely available. So it might be a really good option, at least adjunct treatment to target this condition. Of course, we have to monitor renal function in this population because COVID-19 often can impair the normal renal function in the COVID-19 survivors. So to take home message here, so far we don't have really the gold standard lab test or biomarkers to diagnose the post-viral fatigue syndrome, and impaired creatine metabolism might be something that accompany this perplexing disease. Preliminary studies so far shown some promising aspects of creatine or creatine analogs in post-viral fatigue syndrome or similar diseases. So probably the low dose long-term intake might be something that should be considered. But at this moment, we do not have enough evidence to really endorse creatine for chronic fatigue syndrome. We have to explore it in much more details, and perhaps the post-COVID-19 fatigue syndrome might be the first opportunity to build the case for creatine in chronic fatigue syndrome. Thank you for your attention.